It's my absolute pleasure now to welcome our Pam Albany Guest Lecturer. I'll just tell you a little bit about Pam. Some of you in the audience I know remembered Pam. Pam Albany, the late Pam Albany, was from New South Wales Health and was a passionate advocate for accident and injury prevention across her various roles across her career. And she was a key facilitator for promoting evidence-based practice, for initiating a New South Wales falls policy, and for the beginning of the falls prevention program and also network. And we're still all striving to sort of get back to that situation where there is that real government focus and priority on falls. And so we've, over the years, we have a different lecturer each year who's really made a very important contribution to falls prevention and to the care of older adults. And we choose people from different disciplines who've really made very important contributions. And it's my absolute delight this year to welcome Professor Sarah Hilmer. Now, Sarah is an academic geriatrician and clinical pharmacologist. She's the head of Department of Clinical Pharmacology and a senior staff specialist in aged care at the Royal North Shore Hospital, as well as a conjoint professor of geriatric pharmacology at the University of Sydney. Now, Sarah leads an amazing translational research program in ageing and pharmacology at the Colling Institute, and she covers basic clinical population and implementation studies that are all about understanding the effects of medications and of deprescribing in ageing and frailty. Her clinical research, education and policy work all aim to improve outcomes of medications for older people. And I know she's the prime example of a clinical academic who talks about being able to implement the results of her own research in her own care of patients, which is very inspiring. So Sarah's, the title of her presentation is Optimising Medications to Minimise Falls. Welcome, Sarah.
Thank you very much, Kathy. It is a great honour to be giving the Pam Albany Lecture today, and I'm going to touch on some of my work around how we can better prevent falls through better management of medicines. Just as a disclosure, I'm an inventor of the Drug Burden Index, which is a clinical risk assessment tool for reducing medication-related functional impairment, including falls, and Northern Sydney LHD is currently looking into commercialisation of that. I'm employed by Northern Sydney LHD with a conjoint appointment at the University of Sydney, and my research is funded by government, institutional grants, and by philanthropy. So the key take-home messages today, in case you lose track somewhere along the way. Firstly, medications affect healthy ageing both positively and negatively. Secondly, medications are one of the commonest and most modifiable risk factors for falls. And thirdly, medication review is never a waste of time. So firstly, medication review is central to age-friendly health systems, healthy ageing and falls prevention. So this is the 4Ms framework of an age-friendly health system. And I've got a picture of Mary Tonetti there in the bottom corner. Internationally, Mary Tonetti is really the first person who said, falls are not just something that happens to everyone when you get older. Falls have risk factors that are preventable. And she's done a lot of work on implementation that has led this field internationally. So she led this age-friendly health systems framework, which is promoted in the US, and we have a very similar one here. It's the 4Ms, catchy and easy to remember. The 4Ms are what matters to the person, their medication, their mentation, and their mobility, which of course includes falls. And you can see that medication is a major influence and needs to be considered when thinking about how to give people what matters to them, align their meds with their priorities and their goals, help people optimise their mobility, minimise their risk of falls and gait slowing through centrally acting meds and meds that drop their blood pressure, and optimise their mentation, stop those medicines that slow down your thinking if you possibly can, like sedatives and anticholinergics. So when we think about locally our falls prevention framework, clearly medicines and medicines review is part of this, but as Bryony beautifully said, it's really a multifactorial intervention, and I've underlined those things which are directly influenced by medicines. So while we absolutely are thinking about multiple factors, when we think about those factors, we need to think about medicines as well, because they are a major modifiable factor on all of those. Now we'll talk about the role of drugs in healthy ageing. When we think about the WHO framework for healthy ageing, we think about a person's intrinsic capacity and their extrinsic environment. When it comes to a person's intrinsic capacity, you can see that medicines can have a very positive effect. They can help you prevent and manage disease, and that will help you age well. On the other hand, their side effects can impair function and actually reduce your intrinsic capacity. And to make this a little bit more complicated, which I'll go into a bit more later on, there's a two-way relationship between medicines and exercise, nutrition, and social engagement. Here's just a really simple example with nutrition. About a third of medicines may give you a sort of anorexia or GI symptoms and sort of put you off your food. What do you know? You're less likely to eat. You wind up with malnutrition. Often nutrition and eating is a social activity, and you might be less likely to go to your social engagements. So even those very subtle and very common side effects can affect other things that influence healthy ageing. On the bottom there is extrinsic environment, and clearly access to health services, including medication review, and access to medications is a big part of enabling drugs to be used in a way that facilitates rather than hinders healthy ageing. So I thought it would be only fair to talk about the World Fall Guidelines and what they say about polypharmacy, fall risk increasing drugs and falls. And what you can see is that the recommendations are right through the continuum of care. We recommend assessing for fall history and the risk of falls before prescribing potential fall risk increasing drugs, so primary prevention. We recommend the use of a validated structured screening tool to identify falls risk increasing drugs when performing a medication review. We recommend that medication review and appropriate deprescribing of falls risk increasing drugs should be part of multi-domain falls prevention interventions, not standing alone. And we recommend that in long-term care residents, the falls prevention strategy should always include rational deprescribing of fall risk increasing drugs. All these recommendations are strong, but the evidence to support them is intermediate or low in quality. And I'm going to talk about how we actually can use some of these in practice. So as Bryony beautifully said, we can't work in a silo, and medication review actually doesn't work when you do it in a silo. This is a really nice meta-analysis that showed that actually if you just do a medication review, you're not going to make a difference to falls. But if you do a medication review with a multidisciplinary assessment in either a long-term setting or a frail subgroup of people, then you're much more likely to be able to use that medication review to reduce falls. Now, when we're thinking about a medication review for somebody who we're trying to either primarily or secondarily prevent falls, there are a few things that we need to think about. Clearly, the what matters most, aligning their drug use with their goals of care, minimising their falls risk, which is what I was asked to talk about today and what I will focus on. But we also need to think about minimising the injury risk. If we know someone is at high risk of falls, then we want to do everything we can to minimise their risk of hurting themselves if they do fall down. So things like osteoporosis management are really important to reduce fracture risk. If someone needs an anticoagulant to manage their medical problems, either to reduce their risk of falls or treat a pulmonary embolus, reduce their risk of stroke or treat a pulmonary embolus, then we have to work really hard on making sure that we use that as carefully as possible so that they're in a nice therapeutic range. And we have a discussion with them about the fact that, if you do hurt yourself and cut yourself or bump your head and you're on a blood thinning agent, you will bleed more, and what that means to them. And then we have to think about the intersection of medications with other interventions that reduce falls risk. And because a lot of you are physios in this audience, I thought I would just touch on the interaction between medications and exercise. So on one hand, exercise can reduce the need for medications. For example, if you do a lot of exercise, then you reduce your cardiometabolic risk factors and your risk of cardiovascular disease, and therefore your need for cardiometabolic medications. Similarly with musculoskeletal disease, if you exercise and control your symptoms, then you may not need strong painkillers. Exercise can also reduce adverse drug reactions. For example, things like anorexia, osteoporosis, orthostatic hypotension and muscle atrophy all respond really well to exercise. But you also have to remember that medications can affect your ability to exercise. And if you're a person implementing an exercise program, you need to think about this. And Maria Fiataroni Singh from the University of Sydney talks about this a lot. And in fact, this is a citation from one of her papers. For example, if someone's on medications that are sedative or anticholinergic and impair their cognition, they're going to have more trouble following your directions and being alert for their exercise. If someone's on exercise that impairs their balance, you've got to be really mindful of that when you're trying to do standing exercises and balance training, and you might want to in fact do that more intensively. And some medicines impair your cardiovascular response to exercise. Things like beta blockers will make it harder to respond to aerobic exercise. And so really important to consider that one of the reasons why medication review probably doesn't work terribly well in isolation, while multidisciplinary falls prevention works really well, is that there are these complex two-way interactions between our medicines and the other interventions that we do for falls prevention. So the next question is, whose job is medication review? And this is a study that we did looking at perceptions of hospital clinicians around a number of local health districts in New South Wales. And we looked at a number of different components of medication review related to deprescribing. Identifying polypharmacy, conducting the actual review, monitoring for adverse drug reactions, recommending alternatives, and communicating within the multidisciplinary team. And what you can see is that pharmacists and senior doctors think that everything's their job, and that's probably true. But it's, about a third of allied health and nurses and junior doctors also recognise that they have roles to play, and this is absolutely a multidisciplinary task. So now I'm going to talk about polypharmacy and deprescribing, two of my favourite subjects. So why is polypharmacy important in older adults? Well, firstly, it's really common. More than half of older adults use polypharmacy, which we define as 5 or more medicines every day, often to manage multimorbidity. And in this context, it's important because polypharmacy increases the risks of falls, frailty, and delirium. And this is just a summary of the risks of polypharmacy in older adults. So there are pharmacological risks. The more drugs you're on, the more likely you are to be on a drug that is inappropriate for you. In other words, the current risk of harm to you outweighs the current benefit to you. The more drugs you're on, the more likely you are to have a drug interaction, and the more likely you are to have a prescribing cascade, which is where you use one drug to treat the side effects of another drug without realising that you're doing it, and you wind up in a mess. There are also clinical risks with polypharmacy. There are adverse drug reactions, geriatric syndromes, including falls, hospitalisation and healthcare utilisation increases, and winding up in a nursing home or dying also increases. And there's significant patient and carer burden in polypharmacy. There's the time it takes to, get the prescriptions, buy the medicines, administer the medicines, and the cost, which does accumulate. So on the left here, we have a study which we did in the Concord Health and Ageing in Men project, which is a group of 1,800 older men who live around Concord Hospital. And we looked at the cut-off for the number of drugs that causes bad outcomes in older people. And, geriatricians had always said, once you're on 5 or more drugs, you're in trouble. And one of Mary Tinetti's famous quotes is, which drug is the most dangerous in older people? The 4th drug. And what we saw was the cut-off for risk for falls was actually about 4.5 drugs. So, 4 or 5 is a pretty good guess, and it's now substantiated quite well by data. Ours and then a number of other studies internationally have reaffirmed that. But, all this data comes from observational pharmacoepidemiologic evidence. And you always wonder, is this residual confounding? Are these people, just really sick, really frail, and that's why we're seeing these patterns we haven't controlled properly? Now I'm going to talk about deprescribing. So deprescribing is an Australian word. Be proud of it. It was first published by Michael Woodward in our local pharmacy practice journal in 2003. I published my first paper using the word in 2004. And deprescribing is the process of withdrawal of an inappropriate medication supervised by a healthcare professional with the goal of managing polypharmacy and improving outcomes. Why is deprescribing important for older people? Firstly, because we have limited evidence of benefits of prescribing medications in older people with multimorbidity, polypharmacy and frailty. So we don't really have a strong conviction that these drugs are helping. Secondly, because we actually have known risks of polypharmacy in older people, which we just covered. And thirdly, because it's person-centred. No one likes to rattle when they walk. This diagram shows that very nicely. So this is from some national recommendations that we made around reducing inappropriate polypharmacy in older people. And you can see that approximately half of all older adults are taking medicines that are harmful or unnecessary. And 9 out of 10 older adults will be willing to stop one or more of their medicines if their doctor told them it was possible. This is patient-centred care. And a famous quote from geriatrics, once noticed, a side effect of a drug is probably the single most reversible affliction in all of geriatric medicine. So the key thing is noticed, and it's up to us to try to notice. So what do we know about the effects of deprescribing? Well, there are benefits. You get less adverse drug reactions if you have less drugs, and less treatment burden from taking lots of medicines. There are also potential harms. You can get adverse drug withdrawal reactions, particularly if you stop a drug suddenly, and that's particularly true for drugs that act on the central nervous system, drugs with anticholinergic effects, and steroids. It's also true for beta blockers. You get a rebound tachycardia that can give you angina. You can get a return of the underlying condition or failure to prevent the condition that you were trying to prevent with the drug in the first place. And you rock the boat. So by taking away a drug, it's not that different to adding a drug. You wind up influencing the pharmacokinetics and pharmacodynamics of the remaining medicines. Now, there have been a number of randomised controlled trials of deprescribing now, and actually a growing number of systematic reviews. And when you look at deprescribing a single drug class, like a benzodiazepine or antipsychotic, it's been shown really clearly that that's feasible, it's safe, and you see some improved clinical outcomes, particularly falls reduction. When you look at deprescribing inappropriate polypharmacy more broadly, it's feasible, but usually fairly limited in terms of what you can actually implement in a study. It's safe, and there's fairly limited evidence of clinical impact in terms of things like falls reduction. Now, it's clearly not just the number of drugs, 5's a magic number, but it's not just the number, but also the type and dose of drugs that increases falls risk. And there are a number of lists of different falls risk increasing drugs, and essentially they're all very, very similar. Anything that acts on your brain or acts on your cardiovascular system is likely to increase your risk of falling. On the right here, I have the stop fall criteria, which is an international consensus around Europe around which drug classes were thought to be associated with falls, and they are exactly those. So the drugs that act on your brain and the drugs that act on your cardiovascular system. There are also a number of local lists available, including some from New South Wales Therapeutic Advisory Group, which I currently chair, which are available free online and are good, useful hospital resources. And if we're reducing falls risk increasing drugs in hospital, you'll see right at the top is benzodiazepines. And we know that using benzodiazepines to help you sleep in hospital is one of those things that is going to double your risk of falls. And we know that we don't want to do it, but actually, despite that, it's really hard when someone's agitated and really wants to sleep to not sometimes call the JMO and say, please write up some night sedation. So commissioned by the CEC, New South Wales TAG put together this package called Getting It Right for Sleep at Night, which talks about all the things we can do at a systems level within our hospital, as nurses, as physios, as OTs, as pharmacists, and as doctors, to try to help people sleep at night without needing night sedation. So really simple things like, quieter buzzers, time the medicine so you don't have to wake the person up if possible, time the OBS so you don't have to wake people up if possible, and give people eye masks and earplugs. It's a small price to pay compared to the cost of preventing a hip fracture in hospital from a benzodiazepine. So when we think about falls risk increasing drugs, one tool that we can apply is the drug burden index, which is the tool that I've done most of my work around. So the drug burden index is a pharmacological measure of an older person's total exposure to medicines with anticholinergic and sedative effects that impair physical and cognitive function. And it essentially takes all those medicines that are considered falls risk increasing drugs and looks at the dose the person takes relative to the minimum licensed or registered dose. And for each of those drugs, you get a score between 0 and 1, depending on your exposure and your dose, and then you add them up to give the person their total score. It's been evaluated in older people from the community, retirement villages, nursing homes and hospitals around the world, and higher drug burden index exposure is associated with impaired physical function, falls, delirium, frailty, hospitalisation and GP visits, and mortality. And this cartoon says it all. I prefer to organise my pills by side effects. This one makes me sleepy, this one makes me moody, this one makes me tired. And that's what we've done with drug burden index. Drugs with anticholinergic effects are often side effects, not their primary mode of action. So you might have someone with, an anticholinergic that they're absolutely using for its anticholinergic effects for their bladder, but also an anticholinergic effect of an antidepressant and an anticholinergic effect of an over-the-counter antihistamine, and all those add up to slow the person down physically and mentally and increase their falls risk. This is a meta-analysis that Bonnie Liu, who is a geriatrician just finishing her PhD with me, did, looking at the association in the DBI and a number of outcomes, including falls, and you can see that the higher your drug burden index, the more likely you are to fall. Now again, this is very much observational data, and if we really want to understand causation, reversibility and mechanisms of the effects of polypharmacy with increasing DBI on frailty and function in old age, it's pretty hard to do in a clinical trial. You can't bring people in, give them drugs, take them away, see what happens to their falls. But you can do that to a mouse. So we looked at these outstanding clinical questions in a mouse model. Are the associations between chronic medication use and adverse geriatric outcomes causative? Is it the number of drugs or the type and dose of drugs, like say the drug burden index, that causes adverse geriatric outcomes? And are these effects reversible with deprescribing? And we used mouse models to determine the effects of chronic treatment with polypharmacy regimens with different DBIs, the monotherapies that went into them, and deprescribing on translatable outcomes in ageing mice. This was a 3-year project that we did at the Colling Institute. It was huge. We had hundreds of mice. And you can see that we aged them to middle age, and then at middle age randomised them to different polypharmacy regimens with either 0 DBI, low DBI or high DBI polypharmacy, same number of drugs, different anticholinergic or sedative burden. And then at 21 months, which is old for a mouse, we deprescribed the drugs, slowly withdrew them like we would in a person, and saw what happened to them by the time they got very old at 24 months. And this is just one outcome. It's called nesting, and it's a good model of ADLs. The idea is that a mouse normally gets nesting material, builds a nice dome nest and likes to hide and sleep in it. And if you have functional impairment, then you won't be able to do that so well. You can actually grade this nest, and the higher the score, the better it is, the more it's got nice symmetrical high walls and a nice dome top. What you can see here is that the black line there shows the mice that just got controlled diet. And right into old age, into very old age at 24 months, those mice built beautiful high-scoring nests. Then you see the 3 different polypharmacy regimens. Each has 5 drugs, but the green has no anticholinergics or sedatives. The blue has a low drug burden index. It just has citalopram as its contributor to the drug burden index. It would give it a score of about 0.5. And the red has a high drug burden index. It's got citalopram, oxycodone and oxybutynin in there, along with metoprolol and simvastatin. And what you can see is that particularly the red line really dives off. By the time the mouse taking the high drug burden index polypharmacy is 24 months, it can't make anything like a nest. However, if you look more closely at the dotted line, you'll see what happens to the animals where we deprescribe the drugs. And you can see that if you deprescribe those anticholinergics and sedatives, even in very old age, the mouse actually can make a perfect nest, even in very old age. So this was really the first causative study to show that it's drug burden index, not the number of drugs, that impairs function in old age, and it's reversible on deprescribing. So I'm just going to touch a little bit on some more translational work to think about whether exposure to anticholinergic and sedative medications impairs gait and whether it's reversible with deprescribing. Clearly in a mouse, which is a quadruped, falls are pretty difficult to model, but gait and falls are tightly related. So we'll look at some preclinical data first. This is a mouse undergoing a gait analysis. This will look very similar to some of the gait analyses that you might be doing on people with all sorts of leads on in a gait lab. And what we saw in that was that, again, the high DBI polypharmacy impaired a number of different aspects of technical measures of gait, and it was reversible on deprescribing. This is a study, an observational study that was done by a colleague in the Netherlands in a geriatric outpatient clinic. And these are some people who underwent comprehensive geriatric assessment and, again, an accelerometer-based dynamic gait parameters. And again, what we see is that the people who had high DBI polypharmacy had impaired measures of gait. And this is a clinical interventional study that I'm doing with some colleagues in Canada at the moment. And we're looking at older people with a high drug burden index at baseline and reducing that drug burden index and seeing what happens to their gait measures, both lab measures as well as with wearables in everyday activity. We've published the feasibility study and we've currently got about 68 people in the main trial. It looks really promising and there are measurable changes that you can see and improvements you can see with deprescribing even within a few months. But the full trial will hopefully be available in a year or two. We can also use the mouse to get a deeper understanding of the mechanism of effects of polypharmacy and the reversibility with deprescribing. We saw reversible changes in the gut microbiome, in the hepatic proteome. We saw differences with age and sex to help inform personalised medicine. And we saw differences in the effects on the heart using echocardiography and proteomics. And interestingly, differences again between age and sex in susceptibility to polypharmacy effects on the heart. I'm going to finish by talking about the use of the drug burden index to guide medication review in clinical interventional research and in practice. Now, I showed you that equation. It's nothing anyone is ever going to do by the bedside, so we needed to develop some software. This is the first software we developed, which is a web-based platform that's used widely in the community and has been used in hospital settings. And it has a drug burden index calculator. We evaluated in a cluster randomised controlled trial, including a process evaluation, and showed that it could help with home medicines review pharmacists, giving recommendations to reduce anticholinergics and sedatives. It's now been available to registered Australian healthcare practitioners for clinical care and is being used around Australia. If anyone wants to use it, it's free. And we did some national implementation in primary care in partnership with NPS Medicine Wise. It was one of their very last projects before they were shut. And we also did some work with the Aged Care Commission making a version for nursing homes so that nurses in nursing homes could use this to inform their discussions. But, we work in hospitals and I really wanted to see this used in hospitals. So in the very first round of New South Wales Health translational research grants, I put in this application to see if we could get the drug burden index used as a risk assessment tool in hospital. We did 2 studies. We did an observational cohort study across 6 hospitals. We called it 2 Home. And we showed that while everybody has polypharmacy, so it's not much help as a risk assessment tool, actually only half the population has a drug burden index greater than 0, so at least we're not picking up everyone, we're only picking up half, and only about 20% have a high drug burden index of greater than 1. So, and we showed very nicely that it was a higher drug burden index independently predicted adverse drug reactions at hospitals, falls and delirium. Then we worked with eHealth New South Wales to develop a drug burden index hospital intervention bundle. We put the drug burden index into the Cerner EMR, where it's now available in Northern Sydney and Central Coast in routine care, and people can see the drug burden index for all their patients over 65 and track it through the admission. We made an education module with Hetty, which is still available. It's about 13 minutes to tell you what the multidisciplinary team can do in terms of reviewing polypharmacy in older inpatients. We made some quality use of medicines indicators with New South Wales TAG, and we made some deprescribing tools for clinicians as well as consumer information leaflets, which are hosted on the New South Wales TAG website. This is where you can find the deprescribing tools. Part of the EMR intervention was to put the DBI into the pharmacist's patient list, so pharmacists can actually sort their patients by DBI when they're trying to prioritise people for medication review. And the indicators included indicators around identifying patients, performing the review and communicating on a discharge. And we also made some prems. And we found that we had a way to go. Overall, only 20% of older inpatients or carers were aware of the reduction or cessation of their usual medications on discharge, and reported involvement in decision-making and receiving enough information to reduce or stop one or more of the usual medications. And this, I guess, gives us a starting point to improve from. We also did a lot of work around communicating with GPs in the discharge summary. We piloted this during the pandemic. In fact, during the Delta outbreak, terrible time to try to pilot something remotely. But we did actually increase the deprescribing in hospital of anticholinergics and sedatives significantly, and actually made the biggest difference to opioids. We have just finished a step-wedge clustered randomised controlled trial of a stewardship pharmacist implementing medication review using that DBI bundle in 6 New South Wales hospitals across Northern Sydney and Central Coast, with the outcomes stratified by frailty. And we were able to show that actually what we saw in the pilot was generalisable across a range of services and a range of hospitals, not just mine. And we're just submitting that for publication at the moment. And this is one of many trials looking at deprescribing polypharmacy at scale with prescribing and clinical outcomes. I'm also really delighted that that drug burden index software is now being built in Epic to be translated across the state for SDPR. So, final statement. When we're optimising medications to minimise falls risk in older people, why do we do it? Because polypharmacy is a common, preventable and reversible cause of falls. What do we need to do? We need to screen and minimise falls risk increasing drugs, optimise drugs to minimise the risk of injury, and to facilitate engagement with other falls risk interventions. When and where do we do it? We need primary and secondary prevention in the community, in residential aged care homes and in hospitals. Who needs to do it? The whole clinical multidisciplinary team and the patient and carer are active partners in this. And how do we do it? We need to integrate it into our workflows, and that's what we showed with our most recent step-wedge trial. We need to put it into our assessment forms on admission and transitions of care. We can put things like the drug burden index into falls huddles. We can use EMR tools to help us in our everyday work. So, final statement, medication review is never a waste of time, including in falls prevention. I'll finish by acknowledging the many people who I work with and my institutional and funding support. Thank you very much.
Thank you so much. Hello there. Thank you so much, Professor Hilmer. I'm sure you'd all agree that was an incredible talk and so useful. I particularly love the clinical relevance of your mouse studies. I think that's absolutely fantastic. We're a bit short on time, so we might actually skip the questions. Hopefully you're able to stay around at morning tea, so feel free to come and trip over Professor Hilmer. But we would just like to, in recognition of your incredible contribution and really a fitting, tribute to Pam Albany, we'd like to give you a small gift and a certificate. So we've got Dr. Stephen Fu, the coordinator of the New South Wales Falls Network, giving that to you, and we'll just get a little photo. Fantastic. Thank you again, Professor Hilmer.
Thank you.